OMPs assess body joints, muscle action, ligament tensions, fascial resiliency, respiratory mechanics with the body diaphragm coordination and internal organ placement. And through our fine tuned palpation and extremely gentle release techniques, we work to ensure proper postural balance and nerve and artery and vein and lymphatic delivery through the body for optimal health and comfort too. And of course, it includes the face and mouth and throat. Specifically, when we're working in conjunction with dentistry, we want to be able to do the following things. We want to be catching anything that needs a higher level of care that is not part of our scope of practice, and treating the birth injuries to optimize health for surgery helps the release go smoothly. We can also help after the frenectomy, where we're going to help integrate the new tongue function to the rest of the body, specifically the cranial base, the cranial vault, the cervical spine, the jaw, the throat, and the sternum and thorax, and we can carry that all the way down. Another thing we can do as OMPs is keep supporting the parents with the post-frenectomy exercises or the massage, or there's mostly called stretches. Sometimes they're not quite doing them right, and we can just recoach that for them. And lastly, we want to intervene if we find reattachment problems and refer that baby back to their release provider if needed. We really do have a duty to improve the health of young ones so they develop into healthy adults. And we are that point of intervention. I firmly believe every baby needs to be assessed orally, whether their presenting complaint is digestive or latch related or not. Why? Number one, things get missed. They just do. Posterior tongue ties are tricky to catch. You have to feel it, and we can suspect that they're there and we can refer out. And although anterior ties are hard to miss, there is a lot of undereducated practitioners in every stream, not to mention a lot of conflicting information. Just today, and also 2 weeks ago, started new babies and they had anterior ties, and they were released from the hospital by pediatricians that said, well, they're eating fine, so it's going to be okay. It gets a little frustrating. Assessing oral function. If you don't know how to do a good biomechanical oral assessment, and it scares you to think about how do you get that done in a small moving target like a baby, you can learn more on how to do that. And if for any reason you don't have time, or the baby's mood won't allow for an oral function assessment on the first visit, absolutely make a note for yourself that you have to complete it the second time. Okay. And 3 good tips on doing oral checks practically. 1, if baby starts to cry, drop what you're currently assessing, whether it's a hip, a shoulder, whatever, drop it, put it aside, get a glove on, and start assessing the mouth. Why? Babies will calm down as soon as you give them something to suck. Then you can go back to your previous goal, whatever you were working on. So use these times to sneak that oral assessment in. The other time is if baby's rooting or showing signs of hunger, don't just hand baby to mom. Hold on, get that glove on and get in the mouth and assess then. And then they'll start to figure out no milk's coming out of this gloved finger. They'll get mad enough, and then you can pass them over. Okay. But third, and most importantly, practice. If you're not used to feeling the oral cavity, feeling what a good latch feels like, feeling what a bad latch feels like, feeling what a restricted tongue feels like, just be brave, get a box of gloves, tell yourself, I'm going to start learning the range. I treat over 600 baby treatments a year, and it took me a while to get the range. And now I've got it down. So I'm pretty good at figuring out what's biomechanical, what's fascial, what I'm referring out, what I can keep for a little bit longer, fix a few things, and then send it out. So just start developing your skill set. Treatment. We need not necessarily rush to send babies to a release provider. There can be biomechanical issues if, when cleared by osteopathic treatment first, we can resolve some or sometimes all problems. But remember, the restrictions go through the entire body, especially in the upper body, and good frenectomy results can be masked by something like torticollis. Here's some timing tips. It's advisable to book the follow ups closer together if baby's not feeding well, especially if not gaining weight. So by a day or two. Otherwise, you can rebook once a week for 2 to 3 treatments, depending on results. Um, and depending on your level of expertise, everyone's at a different level, I would say. If you don't see improvement or little to no improvement in oral function after 2, 3, 4 treatments, and you feel a restricted OA, you feel tightness in the mylohyoids and the geniohyoid muscles and under the tongue, look, don't doubt your skill set. Don't doubt your palpation. It's very likely there's a deeper issue, and that's when you're going to refer out. Remember, there's nothing wrong with waiting for a few days to see if your treatment's going to work and set them up for a good future potential surgery. I love incorporating home care ideas for the parents. Number one, they often ask me, "Hey, how can I help my baby more at home?" Parents care. Of course we do. And we want to try to help. So if you feel it's pertinent and necessary and helpful, you can suggest wash your hands very well, trim your fingernail, massage under the tongue and up and close to the frenulum right underneath once each morning and evening. And if you're concerned about the lip, they can do that up there. You can tell them, hey, massage the pecs, the chest, anywhere near the anterior part of the body and the uppers, because everything gets pulled up and in after birth, and that can help open up some space. I like to suggest limiting pacifiers because they keep the tongue down in that low resting tongue posture, and it trains baby for later on in life. You don't want them so reliant on the pacifier that when they lose it out of their mouth, parents have to keep waking up to put it back in. I coach parents to close the baby's mouth frequently. If the baby can breathe okay nasally, or a young child, try to get them to close the mouth so that you get that proper tongue resting posture, because the tongue is our natural palate expander. And make sure in all cases, rebook either growth spurt if it's not too far away, because growth spurts go 2 months, 4 months, 6 months, 9, then 12. So 9, 12, they start to spread apart, right? At first, they're 2, 4, 6. So if you're starting to see a baby very, very young, maybe you don't want to wait till the 2 month growth spurt. Maybe you want to book them at 1 month. Insist gently that it's a good idea. Why? Because there's going to be growth happening. They grow so quickly. And if the mandible and all the other cranial structures are changing, and you're on the fence, or it's a case where it's one of those posterior ties, you're not sure what's going to happen here, with use, with growth, you can check to see sublingually if the frenulum and the fascia is actually loosening and growing and stretching and lengthening with that growth. And parents really appreciate your thoroughness by suggesting that. And without a doubt, we can always use a review of our anatomy and physiology. Remember, the jaw needs to be able to open wide enough to achieve a good latch, and it also needs to be able to protract and retract for good suckling. The maxilla must relax down and not be too high and vaulted. So depending on appliances in birth applied to the head, sphenobasilar joint dysfunction, you can be caught in a high pattern, and the hard palate will be caught high, and the tongue can't then reach the hard palate to undulate and make a good swallow. And that can be concerning if you go and then release the tongue, because what's the tongue going to contact? It's not trained yet. That's just one example of why you might want to just hold off for a couple of treatments as long as baby's gaining and doing okay. Hold off on that referral. Try to get some of the cranial issues to relax down, so post-surgically, the tongue has a better chance to touch the hard palate. The tongue must be able to come down around the finger for complete suction, with the cheeks and the posterior pharynx to be able to elevate for good suckling and optimal swallowing, undulation, and have good motor tone. Proper resting tongue posture is our goal. Let's talk about the lips. The lips need to be able to flange on the breast tissue without gaps, and they need to contract just enough on the breast tissue, but not too much, or else you see those little blisterings from the overcompensation for the baby trying to hang on. Remember, the shoulders and upper thorax to throat connections. Wow, so important. The suprahyoids control the floor of the mouth and posterior pharynx to swallow, and the tongue is attached to there. And then the infrahyoids that are attached to so many places down to here, those are the stabilizers for swallowing. So, of course, it's always full body treatment, but think of all the things that could change after release or what you could change before the release to make the release happen successfully. Again, a helpful link so you can learn more about actually what am I doing in the mouth? What's it going to feel like? And how should I relate this to the osteopathic principles and the anatomy that you know? So you don't have to all go digging into your anatomy books again. It'll all be very complete for you. And just contact me if you need any information.